Recording starting now. So thank you for joining us and good morning and welcome to another media briefing from UNC Health. Today, our 30-minute call will focus on how UNC Health hospitals are treating patients during the crisis, protecting staff and preparing for more cases. Specifically, we'll discuss life in the emergency department in areas of critical care at UNC Medical Center and UNC Rex. And then if you have any other questions, we'll get to those as well. So Alan Wolf will introduce our subject matter, and then we'll have some opening remarks, and then we'll take your questions. So Alan, please go ahead.
Morning. Thank you for joining us. I'd like to introduce our experts on today's call. Dr. Abhi Mehrotra is an emergency physician who has been overseeing the UNC Emergency Department response to coronavirus at UNC Medical Center in Chapel Hill. Dr. Francis Castiller is Director of Critical Care at UNC Rex Healthcare in Raleigh and has been working directly with many of the teams preparing for coronavirus patients. Dr. Mehrotra, I wonder if we could start with you and just give some opening remarks, maybe explain a little bit about what your role has been during the past month, and then we'll switch over to Dr. Castiller.
Great, thank you. Good morning, everyone. Yes, my name is Abhi Mehrotra in the Department of Emergency Medicine and working closely with our response at both the Medical Center in Hillsborough, along with our system EDs. And to this point, it's been a team effort. It's been coordination between our nursing leadership, hospital leadership, and physician leadership to be ready to care for our patients arriving. And the real impact has been almost a complete change of our processes during this period of time, and making a mindset change from thinking about this being a sprint and a single event to address versus more of a marathon, and being prepared and having a preparation phase, a phase where we're more deployed, and then a recovery / how do we get back to normal phase. And so it's been a process of kind of sorting out and separating out and directing patients appropriately, putting into effect a tent process out front of the emergency department so we can screen patients appropriately, direct them to the appropriate area of the emergency department, instituting a telehealth evaluation process at the emergency department, creating respiratory and non-respiratory areas of our EDs, and then changing the processes for patients that are admitted to the hospital from the emergency department. Keeping in mind the emphasis on safety of our patients, safety of our staff, and safety and service to our community. So really trying to be stewards of our personal protective equipment, communicating with patients, utilizing technology that we may not have used before, and then figuring out a process for integrating patients back into the community once we're in the hospital. That's been the focus of our effort, is learning from each other, learning from our colleagues in other areas of the country, and using our time wisely to prepare as best as we can.
Dr. Castiller, would you like to describe a little bit about what you've been doing and your team?
Sure. I echo a lot of the things that was just said. So I lead a critical care group at Rex Health, and a lot of the things we've done have been also along the lines of preparation. Not only preparing our team, we're used to handling a lot of critically ill patients, but also preparing the hospital for taking care of potential capacity or a census that exceeds our usual numbers. So I think for the most part, we've collaborated with a lot of the other departments, ER, a lot of service lines to prepare the hospital for taking care of a potential surge of the COVID critically ill, and had the luxury of time and from learning from not only from our neighboring institutions, but from experiences from across the country. One of the benefits that my team has had is we've divided a lot of the tasks on how to address what we're about to face. I have providers that look specifically at different clinical protocols. I have providers that look specifically at how to staff and model not only our, but how to prepare the hospital to the staff COVID critically ill. So a lot of it has just been that, a lot of preparation. And again, since we haven't had large numbers, we've had the opportunity to learn a lot from just a small number of patients that we've had. And we have learned a lot. A lot of the areas that have been sort of controversial in the clinical care of these COVID patients, just from our direct experience, we're learning more and more how to get these patients through their illness. And so far, I'd say that we've been very pleased with how our patients have been doing.
Great, and so we're able to take questions now. So if you would unmute yourself if you haven't previously, and please just feel comfortable to just jump right in and begin asking questions. Well, if we need a little help to get us going, one of the things I've been interested in too was, have you had an opportunity to compare notes with other facilities, either within UNC Health or outside in other systems, and what might they be saying?
So one of my roles has been also helping coordinate the system emergency departments. And so looking at what our community facilities are facing in different areas, be it in Johnson, Nash, those facilities, along with our professional societies have created listservs looking at what's happening across the country. So that's been very interesting to see what's happening not only within our area and our region, but nationally, and it's variable depending upon the infection and the prevalence of disease in those different areas. Colleagues in New York City have a very different experience than we have in our region right now. And so it's variable depending upon where you live, what the infectivity is, and what the response and preparation time has been. As I mentioned in the opening comments, having the ability to learn from others and apply relevant lessons to what we're doing. So ensuring that we're ready for a potential surge of patients, but also how do we care for those patients that are there right now? How do we best separate out to provide the adequate care and appropriate care for our patients? What resources do other facilities need that we may or may not need at the medical center? And so having that experience, I think, makes a big difference.
We do have a number of news media on the line, so we would open up and take any questions from the media.
Yes. Okay, can you hear me?
Yep, we've got you, Tyler.
Okay, yeah. So I'm here in Smithfield, and I know we have two different facilities in Johnston County. We have Johnston Health in Smithfield, and we have a facility in Clayton. So I wanted to see kind of what the conditions are for ER workers here. What kind of, I know in Smithfield they've had a lot of COVID-19 patients. So I wanted to kind of get a feel for, what's going on there, what kind of procedures or policies are being changed to better, adapt to COVID-19 and what readers should know.
Tyler, thank you for the question. And it's been very similar. We've been able to utilize this time for preparation to, again, best stream where patients should be treated in the emergency department, creating respiratory versus non-respiratory areas, looking at increasing our testing capacity so that we can, again, best stream where patients should be treated in emergency departments across the area, including at both the Smithfield and Clayton campuses. Got a great leadership team there of both the medical directors and the nursing directors in their EDs who have been engaged with us on our planning calls twice a week. So working locally, but then also coordinating across our system. And so been able to share our treatment algorithms across the sites, share concerns about, do we have enough PPE? Yes, we do. How do we best deploy that? So that's been a real blessing is the group of emergency departments across the system, being able to work together, learn from each other, identify issues, and bring that up. A simple example being something that was trialed at Smithfield and Clayton, and then we've now taken across the idea across to our system EDs is using baby monitors in the room as a kind of a simple walkie-talkie, so that you can limit the number of times that you need to go into a room dressed in PPE, exposing staff, exposing patients, and utilizing the PPE. So those are the small kind of on-the-ground tips and tools that we've been able to share across our system by working together cooperatively.
Hey, this is Richard Stradling from the News and Observer. I wonder if you could describe how busy the emergency rooms are, not just with coronavirus patients, but with patients overall. I'm wondering if you've seen a decline in your other traffic while you've been preparing for the coronavirus.
Hi, Richard. Thank you for the question. Yes, and I think we've seen this across our system EDs as well as nationally. In those areas that haven't hit a major surge, emergency department volumes are down, somewhere around the rate of 40 to 50% of our usual volumes. So the question is, what is going on there? And I know that there's been some news articles recently addressing that have come out. That's one of the things that concerns me, is that patients are not seeking care that need to be. And so we have seen a decrease in volumes, and those patients that are arriving do tend to be sicker or non-COVID related complaints than we traditionally were seeing. So that is an open question. We'll have to see what happens in the next few weeks as people end up seeking care.
Dr. Castiller, have you seen similar drop-offs in your areas?
We have, especially with the reduction of elective procedures. So there's been definitely a less volume on the inpatient side, and I agree that the drop in ER volume, we've seen a lot less critically from the. And the ones that do come with illness have tended to be a lot sicker, probably because of delays in recognition and care. So that's a very valid concern. And as time goes by, that may add to the numbers that we'd see if, in terms of critically ill, if as the COVID numbers potentially increase, that patient type would increase as well.
So we do have a really good number of media on the line, so please just jump in and ask a question at your convenience.
Good.
Well, this is Andrea Blanford with ABC 11. I'm just curious if this delay in people seeking the healthcare that they need, do you know what percentage of these folks are waiting to come in due to a lack of health insurance coverage at the moment?
Hi, Andrea. Thank you for the question. That's an unknown. I don't know if lack of insurance coverage is something that's causing folks to not seek care, or is it a safety concern? We've done everything to our part to, again, best stream where patients should be treated and look for the safety of our patients, our staff, and be able to serve our communities. So we'll have to see where that ends up. That's a good question. I don't know yet. What's the cause behind patients not seeking care? We don't think that magically there's been a significant change in the illness factors that are in our community. That the number of heart attacks, strokes, appendicitis has gone down over this period of time. But we'll have to see what happens and where things end up once we get through this.
Dr. Castiller, have we seen more in the critical care area? Have we seen this similar drop-offs?
We have, for sure. Our stroke folks scratch their heads and have the same questions. I think they know that the incidence is probably not changed. People are just not seeking care. So it's across the board, strokes, heart attacks, and emergency surgeries. We've seen drops in all of those things. So our concern is we'll have a surge of all of those in the coming weeks once those diseases run their course.
Great.
I have two questions.
Good. Please go ahead.
One, and Phil, you may be able to email me this later. One is I wanted to see, what the current number of COVID-19 patients is at the Smithfield facility. My understanding is all COVID-19 patients in Johnston County are being seen at the Smithfield facility. And then the second question I have relates to the challenges that are currently being faced by ER doctors. Like what are the most pressing challenges? Because certainly this is, and I guess nurses for that matter, because certainly I know they're having to adapt, and this is probably unlike anything they're used to, on a daily basis.
So Tyler, I think Phil or Alan should be able to get you the data. We have a dashboard that's updated on a daily basis of the COVID numbers at each of our facilities. They should be able to get that data for you. In regards to challenges being faced, I think, again, this is a team-based effort. And so it's not just the physician staff or the nursing staff. It is everyone in the emergency department and in the hospital that are facing these challenges. So, a few examples being the having to don and doff PPE going into patient rooms takes time, takes effort, and takes a concentration to do it correctly, to make sure that you are not potentially exposing somebody else or yourself if there's a patient under investigation for COVID disease. So that time definitely takes a toll, along with adding a new process in treatment of patients. So originally we had very limited testing available, and the testing criteria were very stringent. So kind of operating in a little bit of a vacuum. You didn't know what you were working with and going off presumptions. Luckily, we've been able to change some of that testing so that we've been expanding our testing criteria, even though it looked like it was going to take a long time for those tests to come back. And then working very closely with our lab and the excellent colleagues there, they've been able to deploy a rapid test with very limited supply, but a rapid test that now we get a response back within about an hour. And that's been something that's been a significant change for us and many of our system sites, to be able to then now take a patient who's under investigation or who presents with COVID-related complaints and be able to say, no, we think this is something else that you need to be admitted to the hospital for, but not COVID disease. And so that's been a significant change. Going back to your question about the changes that we've seen from our nursing staff and physician staff, you're right. This is something that we haven't necessarily seen before, but we've prepared for this. This is what we've trained for. This is part of the training in emergency medicine and emergency nursing is to be ready for these sort of instances, be prepared to don and doff PPE, take care of patients with uncertain disease coming in. And so we're doing everything we can to reinforce that training, to be prepared and to help care for our patients.
We have a couple of questions that were sent via the chat function. So, are folks expressing a fear of being in an ED that's got COVID in it?
Again, the good question. We don't know. My fear is that patients aren't coming to seek care because they're concerned of contracting COVID disease. And I'd just like to reassure folks that we've done everything in our capability to stream patients appropriately, take precautions in evaluating patients, both for their safety and for our staff's safety in seeing patients. And with the prevalence we're seeing in the community, I don't know that being at the hospital or seeking care in an emergency department is more dangerous than anywhere else.
Another question via text that we got in the chat function said, UNC Health has a large network of hospitals. How often are you making transfers to the main UNC hospital in Chapel Hill? And are you using that facility's size and expertise as the receiving hospital for some of the sicker patients?
Great question. Our usual approach for this process is to be able to treat patients in place. We've got a significant number of ICU beds available. And so as Dr. Castiller will mention as well, treating patients in an ICU with COVID disease is something that can be easily done at each of our sites. And so preferentially keeping patients where they are in their community, I think is the best process. Now, if a patient may need the quaternary care resource and specialists available at the medical center, that is available. But we're doing I think a great job sharing the knowledge that we have across our sites. And that knowledge may best be served coming from one of the community sites that's seeing more patients than just at the medical center. It's a two-way street. But the availability is there, but the preference is to keep patients in their community with the resources they have available.
Great.
And I had one other question real quickly. I guess two. One is, are hospitals adequately equipped in terms of the number of ventilators, number of beds to treat COVID-19 patients? And also, what is a typical treatment regimen for a COVID-19 patient, and what are the focuses in terms of treatment with this illness? Because I'm not sure everybody understands, the gravity of what COVID-19 is in terms of how it affects the body. So I'm just curious in terms of treatment. How does that look? What does that look like?
Dr. Castiller, you want to maybe take that one?
I could take that one. In terms of resource capacities, we've learned that we actually have we're pretty well resourced in terms of supporting these patients. Our initial concern was we would not have enough of resources, specifically ventilators and other critical care resources, and we've done a lot of preparation to make sure that if we had a large number of patients come in, we'd be able to take care of them. Also collaborating with the UNC system in general. In terms of treatment, there's not a lot of specific treatment regimens that have been proven to be effective for COVID. What we've learned is really we use this term in the ICU, bread and butter critical care, which is supportive care. A lot of these patients just need good support and time. And we've taken on this philosophy of just more of a do no harm philosophy, not trying things that haven't been proven to be beneficial, and taking a lot of time to explain these things to the families. I think one of our challenges is there's a lot of things that are being reported in media that the reality is they have not been proven in medical literature to be effective. So we've been very careful about which treatments to offer, to suggest for patients. But from our experience, we haven't had a lot of COVID patients, but from our experience, like I said, we've been very pleased with how our patients have been doing, and it's really just been good supportive care. So one of the most beneficial things we've experienced is just having the time to explain things to the families on a day-to-day basis. And for the most part, that's been pretty well received. And hopefully as time goes by, we'd be able to report, how our patients have done, at least at our institution.
One question in your area was, and I don't know if you'll be able to speak to this, but how many beds have you swung into becoming ICU areas or ICU beds?
We normally have, let me just do some quick math. We normally have about 60 ICU beds at Rex Hospital. But if needed, our hospital can activate about 160 plus ICU beds if we needed to do that. So our administration has done a nice job with rolling out specific units where we wanted to cohort our COVID patients into one specific unit, and as our numbers grew, there were ICUs that opened up. And again, having the time, we've been able to prepare each unit as time has gone by, and also to prepare the staff to take care of each unit. So that's been a pretty smooth process since the beginning for us. Again, we're blessed that our numbers haven't surged as high as other states, and I think even if they did, we'd be very prepared for a large number of patients.
Questions from the media?
I did want to ask, along the lines of treatments, what kind of drugs are being administered to COVID-19 patients? And, because, from time to time you'll see people hooked up to ventilators, or they'll have an oxygen mask over their face. But I mean, I guess what's the common, when someone comes in with COVID-19, I mean, what kind of drugs are being administered to them while y'all offer support and, try to, I guess update the families on a regular basis in terms of how their treatment is going?
For the most part, like I said, it's a lot of supportive type care. So the patients that end up on respirators require certain amounts of sedation and pain medicines to make sure they're comfortable. There's a few other supportive care type medicines that go along with an ICU type patient. In terms of COVID specific therapies, we've only offered them on an investigational trial type basis. We have a conversation with families very early on that these medicines, certain medicines aren't proven to be effective, but there are ongoing trials that they can participate in. And it's been about 50-50 where patients and families agree to take those specific medications. For example, the hydroxychloroquine, azithromycin combination is one that's sometimes offered, or the remdesivir that's been in the news. So we only offer those, like I said, on that basis. Other than that, it's really just some of the routine things that we use in an ICU. If we suspect another type of an infection, sometimes we'll give some of the more routine antibiotics if we suspect that something like that's going on with our patients. But for the most part, it's the medicines that usually go along with routine care of an ICU. Nothing beyond that.
I know we have a question from WCHL. Go ahead, please.
That's right. Good morning, guys. Thanks so much for taking the time to talk with us today. You both have said that PPE levels are okay so far, but Governor Roy Cooper was pretty critical last week of the federal response, saying that more PPE is needed from that end. Do either of you have an estimate of how long your departments could go on using PPE as you are right now before you'd really start to feel the stress of those resources if more doesn't come from the federal government?
Yeah, thank you for the question. This is a really difficult question to assess, and I think the system's done a good job of assessing what's our current usage, where do we anticipate that usage to go, what we call a burn rate of using PPE, depending upon patient volumes of arrivals, the number of times you have to go in and out of a room, and then what's the replenishment rate. We've started to do processes such as sterilizing N95 masks to be able to use them on a second potential time. We haven't yet had to introduce those re-sterilized masks into our supply. But to address your answer, I don't have a specific day or number of when we would quote unquote run out. But we're trying to preserve as much as we can so that we can get through this until the supply is replenished.
Well, it is.
I did have one more question about PPE, a follow-up to that, if that's okay. Sure, just the different facilities that you have spread out across the state. I'm curious if UNC Health, do you disperse the PPE evenly, or are there some areas, some facilities that might have a surplus of PPE while others are struggling to get enough PPE? We're trying to figure out just how adequately stocked some of these places are across the state.
Right, and we may need to get back to you because that's more of a system question there. I mean, see if our experts have that, but I think that might be something we might need to get back to you, Andrea.
Okay, that would be fine. Thanks.
We have run out of time. It's actually a little past 10:30. It's 10:31. So thank you everybody for joining us. We're trying to do these twice a week. Our next one will be on Thursday, and we will send out the meeting invitation for that. So thanks so much for being here today, and that will conclude our media briefing for today. Thank you.